I'm going to talk about the laser treatment of retinopathy of prematurity. I have no financial disclosure. If we look at the current treatment of ROP, I think the first thing which has been talked is you need close monitoring of the oxygen saturation level, so everything would come down. I'm going to talk about the second, that is the peripheral retinal ablation with laser, which is still a gold standard as far as the treatment of retinopathy of prematurity is concerned. And of course, we have targeting vascular endothelial growth factor, where the treatment still remains sort of a controversial because of the safety issues, and vitreoretinal surgery, which subsequently Professor Azad is going to talk. The rationale for treatment is same as anywhere for the proliferative retinopathy, that the stimulus for the abnormal vessels come from the avascular retina, and you want to ablate this whole avascular retina right from here to the ora serrata all around. And the laser treatment earlier than threshold ROP has shown better results and outcome. This was shown elegantly in a multicentric trial ETROP study published way back in 2003. So after that, the indication for lasers have changed. So we have all these indications here, and also I think the much more better way shown here. If you have a zone 1 ROP here, you're going to treat everything stage 1, 2, 3 if you have a plus disease, and this kind of a thing probably never even seen clinically, but in zone 2 you would treat both stage 2 and 3 if there is a plus disease, because it's very important. So plus disease is very, very important to recognize. And aggressive posterior retinopathy of prematurity already shown by Dr. Narendran. I think we have to identify this. This is something which would come with a severe plus disease, location in zone 1 or posterior zone 2, and usually this will lead to retinal detachment straight away without going into any stage. And this is something which you need to treat as early as possible. So if you have a scenario like this here, you might in the top, if you have you can closely monitor it, you might most of the time even follow this, but in case you are doubtful that this patient will come follow, you might treat. Always you would treat these two here. This is aggressive posterior ROP, and you can see clear cut almost stage 3 ROP with plus disease. So at present, laser delivered through the laser indirect ophthalmoscope's delivery system has become the preferred method of treatment for ROP world over, even in the smallest places. I think we all started, some of us older generation people, with cryo, but you see that had not a lot of morbidity. The treatment requirement is you need a laser indirect ophthalmoscope with a 20 diopter or a 28 diopter lens. So you need eye speculum and an infant scleral repressor, or even a wire vectis would do, which I have used for many, many years, for a rotation rather than indentation of the globe. You require topical anesthetic drops, some artificial drops, or maybe saline drops while you are treating to wet the cornea. There is no need for general anesthesia. It can be performed right at the bedside and is effective for the zone 1 ROP. Treatment become even much more easier, which was so difficult with cryo, and it can be used for unstable infants, and there are minimal complications. You require good pupillary dilatation, and you must remember that appropriate monitoring by the neonatologist or anesthesiologist is important. Never feel that you can treat such a baby in your own clinic without any of these being there. So always it has to be treated either in the neonatal intensive care unit or in the operation theater where the anesthesiologist is there. So never do a mistake, otherwise one mistake will land up always you in a trouble where there is no coming back. The laser is delivered through, as I said, laser indirect ophthalmoscope in a less than half burn width apart, and around 90% would show a favorable outcome. So you have a very good treatment available. Like here, this case, you can see this. And you need to use some topical antibiotics or a steroid drops just for a week. And usually we perform a detailed examination after a week. This is the way you would find. This is the case which I had shown you earlier, that the plus disease would disappear first. This is at 2 weeks taken, everything has disappeared. You can see these vessels straighten up, and you want to do this kind of a confluent laser treatment. So the laser treatment is very rewarding. And this is another case. You can see the same. You can see posterior zone 2 disease and even some hemorrhage here. You can see that those vessels, they have straightened up. ROP has regressed, and you can get very, very gratifying results. Laser treatment is possible inside the incubator through the sloping walls in an unstable infant if it is something temperature dependent and your neonatologist doesn't want that baby to be brought out, and or even if you bring it out for treatment, it will immediately go into a problem. So in such a situation, what you do, or you have a half a treatment done sometime for a baby and the child is still for a couple of days, next day you go still, so you can treat inside the incubator. This we had published as a technique in ophthalmic surgery and lasers in 2008. I think when Anand was with me, I think this is that time we had taken this video. You can just treat with the same parameter. Go in through the wall of the incubator, and you can even screen inside the incubator if the baby is unstable. And this is one such baby here. You can see very severe disease. If you don't treat it in time, you will have a problem. And so this has been treated. Looks like that it will never, but you can see very good regression. And even another one with a very, very serious severe disease as shown with some kind of a residual traction there. We did publish on aggressive posterior retinopathy of prematurity in retina, and this is and there was another publication from the group Shah et al. From Narendran's group here. That time there was no name given to this kind of a thing. We used to name it with so many. So I think you can achieve almost like 70-80% success rate of laser treatment in these kind of aggressive posterior ROP. The problem is, I think we are many times satisfied with situation like this. Inadequate laser. Now what has happened? This baby is referred to us much later, although it doesn't look so frightening here. It is very frightening. The whole retina is already pulled up. It is going into stage 4A. Arcade is already narrow. And you look, see, and the person who has treated he feels that he has done a good job. Another scenario, they don't send it for quite some time and it narrows down and it also always start bleeding, and it's such a problem in such a situation. And this is the worst. I always show this, never do this. This is somebody has gone through the fovea. He was much more over enthusiastic than you need to be. I think you need to first always make, I'll say, some sort of a barrage and go beyond that. It's very essential. Otherwise, I don't know what's going to be happening here if this baby is going to be there. You might not always have very good regression like this case. Very severe ROP. You can see it regressed, but with some kind of a residual. So this might need what we call today a lens sparing vitrectomy, and you may have still a good result. I think the big question today is, we have one laser. We might have most of the time a 532 laser. So diode laser specifically for ROP is not a viable proposition. So we have done this study, and in this study we have shown here that either of the laser you use even in the presence of a tunica vasculosa lentis, vitreous hemorrhage, periretinal hemorrhage, you don't produce different results, you don't produce cataract, and you can use the same laser with the equal efficacy. This has been published in British Journal of Ophthalmology in 2010. I think we did this by chance when Anand was there, because some of our diode laser went out of order. I think some of us, those who are involved in work as far as the ROP is concerned in this country, we got together and has published this laser treatment of ROP, the technical aspects, and you can go through. This is published in December issue of Indian Journal of Ophthalmology in 2010. So where all these issues have been addressed. So in conclusion, I would like to say, treat ROP as per the ETROP study guidelines, and you need to have, or also adding to that, aggressive posterior ROP, and you need a prompt treatment with a confluent laser. And if you do that, you're going to get almost 90% success. And at this time, I would still say the lasers treatment is still the standard of care, not injecting probably the anti-VEGFs. Laser treatment is possible even inside the incubator, as has been shown to you, through the transparent wall, even in a most unstable and a very, very small infant. What Professor Azad also alluded to, maybe we'll need to do that right inside the incubator for such a small baby. And you will have, as I already emphasized, 90% success if you do a good laser treatment and timely laser treatment. Thank you very much.